Hi there, my name is Russell O'Brien. I'm a consultant in acute medicine at the Royal Devon and Exeter Hospital, and this is the first of five or so masterclasses that is going to look at the basics and the more complicated aspects of thromboembolic disease. It's also a precursor to a set of masterclasses on the drugs used, both antiplatelets and anticoagulants, although we will touch on some of that today. In this first masterclass, I'll be looking at some of the basics of coagulation, anticoagulation, and just what circumstances predispose people to thrombosis. I seem to spend quite a lot of time dealing with clots in my work as a general physician. And the analogy really is of a blocked pipe and Dyna rod coming out to unblock things. But I'm certainly not alone, and lots of different specialties like cardiology, vascular surgery, all are dealing with vessel disease and thrombosed vessels as a key underlying pathology of a lot of the problems that they see in the patients that they look after. And the analogy of a blocked pipe is quite good. You've got damage to the vessel wall, and then ultimately it gets blocked up by debris. And histopathologically, on this coronary artery, you can see on the right, there's been long-standing damage to the arterial wall through the development of atheroma, and at some point there's been a plaque rupture, and because of the damage and the exposed endothelium, then a thrombosis has stuck itself over that damaged area of the endothelium, and rather unhelpfully has led to a total occlusion of that coronary artery, and this person would have gone on and probably had a full thickness ST elevation MI. So if we kind of look at what the consequences of thromboembolism are, this slide summarises it rather briefly, and this is very, very basic, and hopefully everyone knows this. Clearly, in a normal artery, blood flow is unimpeded, and red cells are carrying oxygen and other nutrients are going down with the blood, and we have a state of health. As atheroma builds up, we have restrictions to that blood flow, and this will cause something called ischemia, where there is not sufficient supply for the demand of the tissue downstream from that occlusion. And the more extreme circumstances, like a heart attack and stroke, is where there is thrombotic occlusion of these atheromatous areas, causing infarction. And on the right, you can see that an artery that is supplying the sort of lower apex of the heart here is occluded by a total coronary artery occlusion, and then you have an area of total infarction and a penumbra of damaged tissue around it. And so this is a common pathology seen in things like MI, stroke, and other conditions as well. I'm going to start off with a bit of a revision around coagulation now, and it's not an easy topic, and I'm going to give it a relatively quick treatment, but hopefully this is a recap for those of you who are sort of midway through the course. And if you're a little younger watching this and this is new, it is something that you need to know in general terms, but perhaps not in too much detail, certainly not day to day. So let's have a quick look at what sort of how the kind of key factors are in coagulation. In health, we've got this situation where there is a good balance between the risk of hemorrhage and thrombosis, and the body wants to keep the blood in the artery, and if there's a damage to an artery or a blood vessel, we need to put a clot on there. But similarly, we don't want clot to form all the time, or in circumstances when there hasn't been damage to an artery, and this is where a lot of the degenerative vascular diseases come in, where there's a predisposition to thrombosis, where there wasn't when the patient was younger. So why do patients get thromboembolism? And then just to define what a thromboembolism, thrombo is thrombosis, the clot, and embolism is where a clot may have broken off from its first point of creation and then gets lodged in an artery or a vein somewhere else. And so these are pretty common conditions. But why do we get it? You might recognize where I'm going with this, and the man that you can see there is Rudolf Virchow, and he defined the well-known Virchow's triad, which you can see here, which is the predisposition to thrombosis and by definition thromboembolism as well. And there's three aspects to this. There's blood stasis, so the blood's not moving, so it's more like a clot. Damage to the vessel wall, which then leads to a clot. Or a circumstance where there is hypercoagulability, where the patient has just got a predisposition to thrombose more. So this is the situation that we see in lots of thromboembolic diseases, where the balance has been tilted in favour of thrombosis and away from bleeding, but pathologically and leading to significant problems. In the final masterclass in this series, I will talk briefly about the prothrombotic states known as thrombophilias, but that's relatively small print. But that's what a thrombophilia is. It's when you've got a state where thrombosis is favoured over hemorrhage. Okay, moving on from that. From the range of thromboembolic disease is very broad, and the cases I've tried to choose during these masterclasses are pitched mainly at sort of middle to more senior students. So I've tried to introduce a few new circumstances and new conditions where thromboembolic diseases occur, rather than just focus on some of the early stuff. If you're a more junior student, maybe look at some of the stuff in years 1 and 2 first. But thromboembolic disease can affect both arteries and veins in the microcirculation. So this isn't something that's stuck in one part of the circulation. It can affect anywhere. This is a very busy slide, and if you want to have a look at it in more detail, then please pause the video now. But this is just a reminder of the stages of hemostasis. Hemostasis is the creation of a clot that prevents hemorrhage, and the stages are the formation of a platelet plug, the initiation and propagation of the clotting cascade, then stopping the clotting before it turns the whole body into one big clot, and then finally during repair, breakdown of that clot and removal of it as well, to restore a normal circulation in that area. So that's what hemostasis is, and we'll just look at a couple of stages on here, but no detail. We could have a whole series of masterclasses on each of these, and I'm going to give them a fairly short shrift. Just recall that platelets go through the stage of activation, and this can be due to exposure to underlying collagen in damaged endothelia. They then stick onto the wall, adhesion, and things like von Willebrand's factors are important there. And then they may aggregate and stimulate neighbouring platelets to also kind of coalesce and produce a platelet plug. And then the final phase is secretion, where a number of factors are released that activate the clotting cascade and further platelet aggregation as well. So that's platelet activation. The clotting cascade is pretty complicated. It's necessary to know a little bit about it, but if you're anything like me, almost impossible to remember. So I'm going to try and simplify it, at least to some degree, particularly looking forward to when we talk about the drugs used to manage thrombotic disease in the next set of masterclasses, so that you'll see the same diagrams there. So this is the kind of thing that you get if you open a textbook, and it's just noise to me. I can't focus on all of that in one go, but the clotting cascade is pretty complicated. So I'm going to try and boil that down if I can, because if you can remember that, then you're either a hematologist or you need help. So let's make it a bit more simple. So if we look at the triggers for coagulation, the cascade, there's two separate pathways that are feeding into what's called a common pathway. One is called the intrinsic pathway, and this is initiated by things like sepsis or endotoxins. And similarly, on the other side, we've got something called the extrinsic pathway, and something called tissue factor, which is released in response to injury, is something that would trigger that. And there's a number of factors then that cascade down to what's called a common final pathway. And this is a kind of summary of what that is. And again, this is complicated enough, but to understand how the clot's formed and how the drugs work, we do need to be at least aware of some of the terms and names down at this end of the cascade. So the common pathway starts at factor 10, which is then activated, and then you can see that right down towards the bottom you've got something called prothrombin, which is activated by a number of other clotting factors above it that produces thrombin. And thrombin then is able to convert fibrinogen, which is a precursor of fibrin, to fibrin, and fibrin is what makes the clot itself. And then this fibrin becomes cross-linked with other bits of fibrin to produce a really tight sort of net-like mesh, and the clot that we see in thrombotic disease. So that's the common final pathway, and knowing things like thrombin and fibrin are important just when we're talking about how the drugs work. It's important for another set of drugs that are used in stroke and pulmonary embolism these days to understand the concept of fibrinolysis. You'll also hear that called thrombolysis, and this is where the cross-linked fibrin is broken down. Uh, the the, um, the factor that does that is something called plasmin, and that comes from a precursor, plasminogen, which is activated by tissue plasminogen activator, or TPA, and that's actually a drug that is used as well as a factor in the body. That produces breakdown products of clot, and they're called fibrinogen degradation products, and notably something called D-dimer, which we measure in the blood as a test, and we will talk a little bit about that in one of the later masterclasses. So I probably haven't helped you very much there because it still looks pretty complicated, but understanding the initiation at the top through the intrinsic and extrinsic pathways is of note, but do concentrate a little bit on some of those terms down at the bottom end of the common final pathway for the clotting cascade, because they're important in knowing how the drugs work, and in fact tests like the D-dimer where those terms actually come from. So the final point I'm going to make just in this sort of revision of the clotting cascade is just that as well as those factors that produce the clot, the thrombus, there are also things called antithrombotic factors. And just a few names to be familiar with are antithrombin. You may see in old books antithrombin 3, but they've dropped that now. And things like activated protein C and activated protein S. And these have antithrombotic effects on the clotting cascade. So they're trying to limit the amount of clot that's important. And these are necessary to know both from sites of some drug action, but also that deficiencies in these systems can produce a thrombophilic state, a prothrombotic state, either congenital or acquired. And we will talk a little bit about that in the final masterclass. So that concludes this sort of quick revision of the clotting cascade and some of the reasons why patients will develop a tendency to thrombosis and things like Virchow's triad. In the next 3 masterclasses, I'm going to expand with some cases on what Virchow's triad means in terms of the prothrombotic state, and also how we would go about treating some of these conditions as well. So I'll see you in the next masterclass. Thank you.